Good morning and welcome to the press conference from the 56th annual meeting of the Society of Thoracic Surgeons in New Orleans. I'm Robin Cohen from the Keck USC School of Medicine and the chair of the Workforce for Media Relations at the STS. The first presentation that we're going to see this morning is entitled Early Discharge is Not Associated with Worse Outcome and Readmission, a preview of enhanced recovery after cardiac surgery. It will be presented by Dr. Chris Malaisrie from Northwestern Medicine in Chicago.
Thank you, Dr. Cohen. My name is Chris Malaisrie. I'm a professor of surgery in the Division of Cardiac Surgery at Northwestern University and Northwestern Medicine. Our project is Early Discharge is Not Associated with Worse Outcomes and Readmissions, a preview of enhanced recovery after cardiac surgery. And this is work done by my resident Andre Sohn as a part of a greater project in ERAS. Enhanced Recovery After Surgery, or ERAS for short, is a protocolized multidisciplinary perioperative care initiative to improve patient outcomes. Shorter length of stay is a welcome consequence, but not the goal of ERAS, which leads to improved overall patient recovery. However, we're concerned about potential unintended consequences as a result of sending patients home in an accelerated fashion. So our objective was to take a look at patients who were discharged after elective cardiac surgery in 3 days or less, and compare that with the rest of the group. And oftentimes people think of cardiac surgery and they think of a prolonged recovery. We wanted to look at these patients who were able to go home in an accelerated fashion and make sure that nothing adverse happened to them in terms of complications and readmissions to the hospital. So our patient group started in 2004, ended in 2017, and we really looked at elective cardiac surgery. We excluded TAVI procedures, ventricular assist devices, transplants, and traumas. And we divided this group into patients who were discharged after surgery in 3 days or less versus the regular group of patients. We did advanced statistical methods, propensity score matching to reduce selection bias in order to see a treatment effect between the two patient groups. What we found was of almost 6,000 patients who had elective cardiac surgery at Northwestern, that about the average length of stay for this group of patients was about 5 to 6 days, which we think is a very good length of stay after cardiac surgery. And we looked at a group of patients who really did leave after 3 days or less, and that was about 2.2% of those patients. So a small group of patients. We did our statistical analysis to balance the two groups, and we ended up with 121 patients in the accelerated group, so 3 days or less. We compared them to about 357 patients in the normal group patients. And you'll see right here that these are younger patients, mostly male, and a very low risk. So STS score, which is a predictor score of mortality after cardiac surgery, was less than 0.5%. Operations that encompass this group were mostly mitral valve surgery, mitral valve repair, isolated CABG, and also aortic valve replacements. When we looked at the outcomes, we found 0% mortality in both groups, so that's good. So no one died as a result of accelerated discharge. And we're very happy to see that patients in the low group shorter stay had very low rate of major morbidity, 0%, so it's as low as you can get. We followed these patients long term, and the survival long term was very similar between the two groups. Of note, important outcomes that were specifically focused on afterwards was readmissions and also postoperative atrial fibrillation. And we found that even though patients were discharged in an accelerated fashion, that these patients were not coming back to the hospital for readmissions. So both groups were very similar. Only about 6 to 8% of patients were readmitted after they were discharged to home. And an interesting association we found was with the patients who were discharged very early, that they had a very low rate of postoperative atrial fibrillation. And remind people that that is just an association, and we can't demonstrate any causality between discharge and postoperative atrial fibrillation. So in conclusion, from what we found in our study, in a patient with elective cardiac surgery, in a young group of patients with a very low risk of operative mortality, then accelerated discharge, meaning 3 days or less, was very safe. So no one went home and had a complication, including rehospitalizations. So this sort of clears the path for us starting an ERAS protocol. And it does answer some pertinent questions from both the patient and our administration about, well, if I get sent home too early, will I have any problems if I go home? And that can be safely answered, no. In addition, your hospital administrator may ask, well, are we going to have an unintended consequence of readmission because we send patients home? And the answer to that is also no. Thank you for your attention. My name is Chris Malaisrie, and I'd like to thank the rest of the co-authors on this important project for us.
Now we're going to do a discussant. The paper is going to be discussed by Dan Engelman from Bay State Medical Center. Dan is also the president of the ERAS Cardiac Society. ERAS stands for Enhanced Recovery After Surgery.
Thank you very much. So yes, my name is Daniel Engelman. I'm at Bay State Medical Center in Springfield, Massachusetts. I'm also an associate professor of surgery at the University of Massachusetts. And I'm also the president of the nonprofit International Enhanced Recovery After Surgery Cardiac Society. So really, I'm here to answer questions about ERAS as a whole. And what Dr. Malaise has showed in this excellent study is that some of the worries that people and patients have had in the past about enhanced recovery programs is that maybe it's all about getting a patient out of the hospital earlier, and it actually is not. It's not earlier. It's actually following evidence-based, standardized best practice in order to get patients out at the right time. And if that's done, like they did at Northwestern, it can be done safely, as he's shown, without an increased risk of readmissions or increased patient dissatisfaction. So what ERAS is following a standardized bundle of protocols, which actually begin preoperatively with an education of the patient and their family about what to expect in surgery, how we're going to work through the operation, how they're going to ambulate early, how they're going to not have that many opioids, how they're going to manage their nutrition, their diet, their exercise, and their transition to home. One can actually improve outcomes. Because it turns out that despite how much work we've spent at meetings just like this, discussing how we operate on patients and the techniques we use in the operating room, that 80% of the preventable morbidity and mortality following cardiac surgery actually occurs outside of the operating room. That means that includes those patients who are inadequately prepared for surgery. They aren't given proper nutrition prior to surgery. They haven't quit smoking, alcohol cessation, gotten their glucoses under control, gotten more exercise prior to surgery and gotten in better shape for surgery, as well as all the complications that are seen after surgery due to mistakes in, say, omissions in protocols, not getting patients off ventilators in a timely fashion, out of bed, using protocolized approaches to preventing infection. Once all this is done in a multidisciplinary effort utilizing nursing collaboration, our advanced practice providers, our pharmacists, our administrators, an entire multidisciplinary team working together in concert toward a care set, we found that we can actually significantly reduce the morbidity and mortality associated with surgery and not have readmissions, which is just what they've been doing at Northwestern. And as they progress, like many, many other hospitals around the world are progressing toward enhanced recovery after surgery protocols, we can predict that our outcomes are only going to get better. And the ERAS Society has been working closely with the SDS, which is absolutely supporting this patient-centered protocolized effort to improve outcomes and allow the patient to participate more in their surgical procedure and their families to get more engaged in getting them home and back to their preoperative state as quick as possible. Thank you.
Very good. Thank you, Dan. Questions for Doctors Malaisrie or Engelman?
Yes.
Hi, I'm Nicole Liu with MedPage today. I'm just wondering how many hospitals or what proportion of hospitals are on board with ERAS?
Yeah, so it depends where you look. So in Europe, in non-cardiac surgery, it's everywhere. It's ubiquitous. Almost every hospital in the UK has an ERAS program. Cardiac surgery is one of the last to actually embrace this because we have so many different elements in cardiac surgery between our perfusionists and our blood transfusions and our multidisciplinary gigantic team and how complicated our surgery is that we were one of the last to join this ERAS movement, but now we've fully embraced it. And I would say that most major programs in North America are in some stage of adopting an ERAS protocol, and it's going to increase as time progresses and the outcomes and the papers will come out.
Chris, did you want to comment on that?
He's got all the numbers.
Lynn Peterson with Trends in Medicine. So when you looked at length of stay, if you took out the patients who had AFib and just compared your non-AFib patients by length of stay, was there a difference?
Right, you picked up on that association very, very well. So postoperative atrial fibrillation has been associated with worse mortality, worse morbidity, and increased resource utilization. That's been shown very, very well. So whether or not these patients didn't get postoperative atrial fibrillation, which led to early discharge, or just that we didn't detect postoperative atrial fibrillation, we cannot tell from this data set. But it does lead to efforts that we're looking at in order to reduce postoperative atrial fibrillation and also detecting postoperative atrial fibrillation as an outpatient with ambulatory EKGs so that we can treat these patients in a safe fashion if it does occur in the outpatient setting.
But I also have a follow-up question. Okay. So if you have a patient with pre-op AFib, and so you do both procedures while you're there, isn't their discharge delayed by their need to get on their warfarin or whatever regimen? So aren't they also, don't you have to take out the AFib patients whether they were pre or post to do the comparison?
I see. So the question is, what do we do with patients who have preoperative atrial fibrillation? Mm-hmm. So we find that these patients do better if we're able to identify preoperative atrial fibrillation because most cardiac surgeons are aggressive at treating atrial fibrillation, including us and Dr. Engelman, at the time of cardiac surgery. So that procedure is best known as the Maze procedure or AFib ablation, which has been shown to ablate atrial fibrillation with up to 90% success rate and up to 80% chance of eliminating anticoagulation in the long term. So if we identify these patients early, that should not impact post-op length of stay.
You can still get them out in 3 days?
We could still get them out. We hope.
Yes.
Yeah, Elle Maxwell with TCTMD. I'm just curious if there are any patients who are not suitable for an ERAS protocol.
Right. I think that, so we focused on elective patients, so we can't make any conclusions about patients who need to be done urgently or in emergent fashion. So we think of patients who had dissections or acute heart attacks. I'll let Dr. Engelman explain the data on this, but we're going to exclude these sort of emergent and urgent patients from our ERAS program.
So my answer is slightly different. I would say that there are elements within the ERAS protocol, which is divided up into preoperative, intraoperative, and postoperative components. Clearly, an emergency patient like he's discussing, there's no preoperative component. We rush them to the operating room. But I do believe that every single patient postoperatively is an ERAS candidate and will benefit from enhanced recovery. And it's low-hanging fruit we're talking about, simple things that people can't argue with, such as reducing the amount of opioids and using multimodal analgesia, getting them out of bed earlier, getting them back to their preoperative state, getting early exercise. So I actually think that there are elements for every single patient and that we should be inclusive and that everybody should be in some degree of an enhanced recovery protocol. It's just that those emergency patients are clearly going to miss out on some of the upfront benefits.
So this is clearly important stuff. I would just add, you mentioned opioids. We instituted an ERAS program in our cardiac surgery program, gave patients their pain meds 3 days in advance, and we were able to cut our opioid use in half. So this is really effective. These strategies are really effective for not only getting the patients out of the hospital earlier, but getting them out in better shape. Would you agree with that?
I would. I think this whole opioid thing actually is enormous, the benefits to the patients as well as society for getting patients out of the hospital on either very low-dose opioids or no opioids at all are tremendous, and we are aggressively pursuing new technological innovations to allow us to get a better sense for, in real time, how many opioids we're prescribing, rapidly decelerate those opioids, and then send patients home on very, very limited doses and bringing them back. If they have pain, we need to bring them back early and figure out why. Because it turns out that a significant portion of patients who are sent out on large opioid doses become opioid dependent. It's probably in the 12% range after cardiac surgery. And it is directly related to the amount of opioids the patients receive in the operating room, post-operatively, and upon discharge.
Other questions or comments? Very good. Thank you very much.
Thank you for your attention. Nice job.
Good work.